Hi, my name is Dr. Chelsea Kadish, and I am your Pediatric Medical Director. And this month's MEC Minute, we're going to talk about pediatric ingestions. We're going to start with a case, and I want you to keep this case in mind as we move through the presentation. You're called to the home of a 12-month-old infant who is unresponsive. Mom reports the child was on a blanket in the living room while she was in the kitchen making dinner. She went to check on him and found him unresponsive. On exam, you note that the infant is pale and has shallow respirations. He's minimally responsive to touch. His pupils are 1 to 2 millimeters and reactive. There's no evidence of trauma on exam, no stridor or wheezing. There's no foreign bodies in the airway. You take his vitals, and his temperature is normal. His respirations are 10. His heart rate's 120. His blood pressure is 85/50, and his oxygen saturation is 75%. So I could talk about pediatric ingestions for hours, but today I just wanted to keep it short and focus on 2 ingestions in particular, and we're going to talk about THC and opioid ingestions. And we'll discuss who's at risk for these ingestions and who's at particularly high risk, what symptoms you might encounter in these patients, and what are some of the key management principles for these patients. We'll start by discussing THC ingestions first. And as I'm sure you're all aware, Ohio passed an issue last summer to legalize marijuana. And then as of August 6, 2024, they also started selling license to sell recreational use cannabis as well. Latest headline is since the beginning of sales for recreational marijuana started back in August, Ohio has spent $87 million just in the first 2 months on these products. Cannabis is legal in several other states, both medical and recreational use, and it's widely available all over the country, not just in Ohio. The amount of Americans who have access to legal recreational marijuana has increased significantly. So in 2017, there was 69 million Americans who had access to legal recreational cannabis. And then in 2021, it was 135 million Americans. Now that it's 2024, that number is even higher. With increased access to these products comes increased exposure. And looking at this graph, we're looking at the accidental poisonings from marijuana in Ohio, and it's broken down by age group here. So the blue group shows our 0 to 5-year-olds, and that is the group that has had a higher rise in the exposures to cannabis products. So since 2019, we've seen 20 times the amount of accidental poisonings from THC products, and the average age of these patients is 2.5 years old. This is all data from our Ohio Poison Center. Other interesting statistics. So the number of calls to the Poison Center has also increased 1,375% between 2017 and 2021, and that's for children under the age of 5 who have consumed THC edibles. And then the potency of these edibles has also increased significantly. The ratio of THC to CBD basically has increased to 6 times what it used to be back in 1995. So they're widely available, and their potency is much higher than it has been in the past. Who is at risk for severe toxicity from a THC ingestion? Children under 6 are at the highest risk, and this is because this is the group who has exploratory behaviors. So babies are starting to crawl, pulling up to stand, walking. They might find things on the ground, and because they're teething and they have this sort of oral exploratory phase, they are often putting things in their mouth that they shouldn't be putting in there. There's also toddlers who walking around the house, opening up cabinets, pulling things out. And so these are the kids who are most likely to have a serious accidental ingestion of THC. Because they're smaller, they just one tiny gummy or one dose of the THC edible can cause severe symptoms. When we look at the packaging for these THC products, a lot of them come in packaging that are also very appealing to young children. Um, and there's really no oversight or limits from the government in terms of how these products are packaged. When you open them, there's usually more than one dose inside, and a lot of these edibles are 100% THC rather than having some THC and some CBD. And when we think about toxicity, we're really talking about the THC that's causing toxicity in children. So yeah, if a child comes and finds one of these packages in their house, of course they're going to want to open it and eat it because it looks just like a candy that they might get on Halloween. In terms of dosing, if we're talking about adults, they say that beginners usually start around a THC dose of 5 milligrams, where an expert might take something like 80 milligrams of THC. Um, A lot of these products, though, have a significantly more THC than what you're seeing on this chart. So this Nerds rope at the bottom of the page has 400 milligrams of THC just in this one rope. Just as a review, the two active ingredients in marijuana are THC and CBD. Again, THC is the one that we're mostly worried about, and this is your primary psychoactive component. And it can cause altered perception, anxiety, difficulty speaking and thinking, slow reaction time. And that's in an adult who is trying to, use the drug recreationally. For CBD, this is the second most active ingredient in marijuana. It doesn't cause a high, but it can be used for conditions like anxiety, insomnia, chronic pain, addiction. It is also FDA approved for a very specific type of child epilepsy, but that is not really the chemical that we're talking about today. Another thing to keep in mind is that a lot of these THC edibles take a while for symptoms to begin. So, smoking and inhaling THC, you'll start to feel symptoms in about 5 to 30 minutes, whereas ingesting some THC takes about 1 to 4 hours to develop symptoms. This can be tricky in terms of um, identifying THC ingestion in children. If they've only just ingested the edible, it's possible that they won't have any symptoms. However, they may start to develop the symptoms much later. So, what are the symptoms that we're going to see in a child who has ingested this accidentally? We can see a variety of symptoms ranging from neurologic, cardiac, respiratory, gastrointestinal, ocular. So it can affect all body systems. The main thing to keep in mind is that with these edibles, which is the majority of the exposures in young children, the onset is slow, and it also can last for a very long time. So typical neurologic symptoms is we see a lot of CNS depression or altered level of consciousness. That would be the most common presentation. Some more severe symptoms, such as seizures or coma, only happen in about 1 to 2% of cases. Other things that we can see in the neurologic department would be things like hallucinations, dizziness, ataxia, where you might see a child walking very off balance, tremor, slurred speech, headache, agitation. These are a lot less common than just generally altered behavior. From the cardiovascular department, majority of patients are going to have tachycardia. Very few patients will have hypotension, and even fewer will have other types of dysrhythmias, such as bradycardia or SVT. Other symptoms that you will likely encounter from the respiratory department, you might see apnea or bradypnea, which is slow breathing. You might see shallow breathing. Generally, I would say there's a lot of respiratory depression happening in these patients. Vomiting is quite common, seen in about 10% of patients. Ocular symptoms, so you might see that they have miosis, which is pupillary constriction, and that can be a little bit confusing because it overlaps a little bit with the opioid toxidrome. Management in these patients is mostly supportive. So, with airway maneuvers, if they have respiratory depression, that's going to be the first thing you want to address. So, just like you would with any other patient, ABCs. So, you can try if they have any type of obstruction, you might want to do, a jaw thrust in this patient, bagging them until you feel like they might need a definitive airway, such as a supraglottic or intubation. Make sure you keep their oxygen levels up. Again, we don't want these children to go into cardiac arrest, although it isn't very common with THC ingestions. Just make sure that you're giving them supplemental oxygen and getting their oxygen back up to normal if it's not already there, because um, respiratory causes are the main reason for cardiac arrest in children. Circulation, because they're tachycardic or potentially hypotensive, these children may require IV access or IO access and a fluid bolus. We have talked about our protocol changes, and one of the changes we're hoping to make is allowing epinephrine for hypotension in children. So whether that is an epinephrine drip or push dose epinephrine, that's always an option too. And then last, consider dextrose. So check out blood sugar in these children. If they have been altered for several hours or vomiting, they're at risk for hypoglycemia, especially in the children who are younger, the 1 to 2-year-old age group. So check their blood sugar and then consider a D10 bolus if their blood sugar is low. What about naloxone in these children? So, lots of studies have shown that cannabis is unlikely to be contaminated with opioids. However, co-ingestions are a possibility, and a lot of our patient population are the families and parents are not great historians. If you feel like the child you're treating has a lot of symptoms in common with the opioid toxidrome, which we already just looked at, and there are a lot of similarities, then I think it is absolutely reasonable to give a dose of naloxone to these children, because the respiratory depression, the altered level of consciousness, and the pinpoint pupils look very, very similar to an opioid ingestion. Again, most children are not opioid users and they're opioid naive, so giving a dose of naloxone is not going to hurt them. If you have a patient who is having seizures as a result of a THC ingestion, then your seizure management is going to be the same as any other type of seizure. So your first line therapy is Versed or midazolam, and I highly recommend giving that intranasally or intramuscularly because it's a faster way to give it. You don't have to mess around with getting an IV or placing an IO. And several studies out there show that intranasal medication or Versed is just as effective as IV. And I wanted to put this little picture down here at the bottom, just as a reminder when you're using the mucosal atomizer that you are pushing really quickly so that it atomizes, and then also make sure you're aiming the syringe toward the back of the head rather than upward toward the top of the head, because that's the way the nasal passages are sort of designed. When thinking about transport for these patients, all of these children should be transported. There was a study that was put out that showed that the toxic dose for edible cannabis in children was around 1.7 milligrams per kilo, and that can predict severe and prolonged toxicity. So when you think about a 10-kilo kid, that's only 17 milligrams of THC that's needed to be ingested for them to have severe symptoms. So if you come upon a child who has a THC ingestion, who has maybe only recently ingested THC, I recommend that you transport them even if they're asymptomatic, because the likelihood that they develop severe symptoms is relatively high. If you are ever in doubt or ever feel like you need help, you can always reach out to the Poison Center. Our Poison Center is the Central Ohio Poison Center located here in Columbus, and they have 24/7 coverage every day of the year. They usually have nurses and pharmacists who staff the phones, and they also have a board-certified toxicologist who then reviews all the cases. The national number, you can Google it if you ever need. It might also be in the protocol, but it's 1-800-222-1222, and that will route you to your nearest poison center. In summary, children under the age of 6 are at highest risk for severe poisoning from THC ingestions. Be prepared to manage respiratory depression, hypotension, and seizures. The toxic dose for THC is very low, and in children, symptom onset is delayed. So please transport all of these children, even if they're asymptomatic. Next, we're going to talk about opioids. The opioids in children are classified in the category of one pill can kill. And these are all drugs that can cause death with just one single dose. And it actually is the most common cause of death from accidental poisoning in the under 5 years old age group. This figure here is showing emergency department visits for accidental ingestions of opioids for children between the age of 1 and 5 years old. And you can see from 2004 to 2011, the number of patients that are being seen for opioid ingestions has increased significantly. The mortality has also increased a lot. It's about 3 times what it used to be back in 1999. And a majority of the mortality is from fentanyl. Another statistics here. So the cause of death for accidental fatal poisoning for children 0 to 5 years old. Back in 2005, it was about a quarter of fatal poisonings were caused by opioids. And in 2018, it increased to about half of fatal poisonings. So just thinking about all the different, fatal ingestions that we see in children, half of them are from opioids. This chart is looking at the annual number of opioid exposure among children by age group, and it's looking at it over time from 2000 to 2015. And this top line, which is our biggest number of exposures up here, this is the group of children aged 0 to 5 years old. And so they're really taking the brunt of most exposures in the United States. Adolescents, however, are not to be forgotten. They also have a pretty high rate of opioid exposure. It is estimated that about 1 in 4 high school seniors in the United States has been exposed to a prescription opioid. And lots of data has shown that these exposures can lead to future substance use, and about 80% of new heroin users have previously used an opioid pain medication. So at Children's, we really try not to send children home with any opioids, just to be conscious about this fact in particular. So unlike THC, depending on the opioid, the symptoms, the onset and the length of symptoms can vary greatly between different types of opioids. So fentanyl is usually very quick. It lasts about 1 to 2 hours in the system, whereas methadone and Suboxone can last anywhere from 24 to 72 hours. And then the opioid toxicity does look very similar to our THC toxicity. And I know that you all are very good at identifying opioid toxidrome in adults. You guys see it all the time here in Ohio. But I know that when we see it in children, sometimes it's a little bit confusing. But basically, it's going to look the same in children as it does in adults. So you'll have altered level of consciousness. There's a potential for seizures as well. They may have low muscle tone or what we call hyporeflexia and just be kind of floppy. Generally, from a cardiac perspective, most patients are bradycardic, whereas THC tend to be more tachycardic. So that could be one distinguishing feature between the two toxidromes. They may also be hypotensive. There's a lot of respiratory depression with opioids in children. Apnea and bradycardia are very common, and shallow breathing as well. And we see meiosis, our pinpoint pupils, and nausea, vomiting, and hypothermia is also quite common in children. So managing our opioid toxicity is going to be very similar to THC. However, with opioids, we actually have an antidote. So naloxone, again, I highly recommend using naloxone, especially in our children under the age of 6. If you are going to be giving it IV or IO, the dosing is 0.1 milligrams per kilo. But again, I recommend giving it intranasal or intramuscular. That way you're not wasting time trying to get an IV. And giving the adult dose that you would give, intranasal or intramuscular, is the same is safe to give to a child as well. So 2 to 4 milligrams would be just fine because most children, especially under the age of 6, are opioid naive. In addition to giving them the antidote and prioritizing naloxone, it's also important to address your airway. In these children, airway maneuvers can be really important because that low muscle tone, they often will be obstructing, so their tongue might fall down into their epiglottic area. So making sure you do that jaw thrust can really help with their breathing and making sure they get the oxygen they need. And then I also recommend that we use bag valve masks for these children until we give our dose of naloxone. If you find that the naloxone's not working, then I feel like it's safe and fair to go ahead and place an advanced airway. But a lot of these children, if they have ingested opioids, the naloxone's going to reverse your symptoms, and then you don't have to place an advanced airway. IV and IO fluid boloids and epinephrine are, again, if the patient is hypotensive and in shock. I had a patient just the other day come into the ER who had gone into cardiac arrest in the setting of an opioid ingestion. The opioid ingestion was not recognized by the EMS team, and the child ended up getting an IO placed. They got multiple doses of epinephrine. They got intubated, and when they got to the ER, they were given a dose of naloxone, and they woke right up. So again, just emphasizing here that prioritizing naloxone can help reverse these symptoms and reduce the need for you to have to do other advanced interventions on these children. So just to circle back to our case presentation, with this 12-month-old infant who's unresponsive, has pinpoint pupils, and has predypnea with a respiratory rate of 10 and hypoxia with the oxygen saturation of 75. This patient was a patient that I actually saw in the ER and had an opioid ingestion. And unfortunately, mom was not forthcoming about the opioid ingestion, which is oftentimes the case in pediatrics. Parents are not really willing to divulge that information because they're afraid that, you know, Child Protective Services is going to take their child away from them, which makes the diagnosis a lot trickier in this population. So this patient ended up getting naloxone in the ER, and the symptoms were completely reversed. So just keep that in mind, that we want to reverse these symptoms as quickly as possible. Summary, opioids are the most common cause of death from accidental poisoning in children under 5. Caregivers may not be forthcoming about the ingestion and makes it more difficult to diagnose these patients. And naloxone is safe for use in children. I highly recommend giving it intranasally or intramuscular to reverse the symptoms quickly. If you have any questions about this, please feel free to reach out to me. Your EMS coordinator has my information. My email is chelsea.kadish@nationwidechildrens.com. Thank you.